Topbed Talk.
This session is a session on perioperative anemia. It's a joint session as an exploratory relationship developing exercise with ERAS UK, and it's my great pleasure to introduce my co-chair, Dr. Rachel Barlow, dietitian by trade, but now leads overseas prehabilitation across the South of Wales. And Rachel, I think you're going to tell us a little bit about ERAS UK.
So I'm just here to do a promo really on Enhanced Recovery UK. So it's great to be here, and it's just really to remind people that ERAS UK is active. It was set up in 2011, and it was basically an international conference held in Bristol. I'm sure many of you were at that meeting. I know I certainly was. And that was really at the height of enhanced recovery across the UK, with many of the nations very much active in that implementation phase. ERAS UK aims to improve the recovery phase perioperatively, and has also been delving in recent conferences to prehabilitation. So there's a natural fit with the work of EBPOM, but also the Prehab Society and also CPOC. So we're working around how we can all complement one another. We have 850 members. The vast majority of our membership is nursing and allied health. We do have quite a few surgeons and quite a few anaesthetists, but the vast majority are on the ground clinical nurses driving enhanced recovery principles. And we're really proud of that as an organisation. We hold one annual conference. We're chaired by Professor Nada Francis, who many of you know is a surgeon from Yeovil and London, and Mike, myself and other colleagues representing the nations of the UK, with the exception of Northern Ireland, actually. So somebody here from Northern Ireland, we're very, very keen to hear from you. Without further ado, I'm privileged to hand over to Scarlett, who will introduce herself, and we can hear about perioperative anemia. Thank you.
Hello, I'm Scarlett McNally. I'm Deputy Director for the Centre for Perioperative Care and an honorary clinical professor at Brighton and Sussex Medical School and consultant orthopedic surgeon in East Sussex. So I'm going to be talking about the new anemia guideline that the Centre for Perioperative Care has written with others. I have no conflict of interest. The Centre for Perioperative Care pay my trust for one session of my time. I'm involved in some other things on a voluntary basis. So perioperative care is from the moment that surgery is contemplated until full recovery. And there are multiple little steps. It's different. I know some of you from around the world, it's different how the different steps are managed. And there are multiple little silos. The Centre for Perioperative Care is amazingly credible. We have all these partner organisations, although it's largely funded by the Royal College of Anaesthetists, for which we're very grateful. We also have a network of clinical leads in most of the acute hospitals in the UK, an advisory group reaching thousands, in fact, hundreds of thousands of patients, organisations and other healthcare staff. So the writing group for the anemia guideline is quite big, and it's been quite fun co-chairing that, actually, pulling together different ideas. And the big thing is it's been making what is normal in one silo accessible to other people. So you might think, oh, goody, another guideline. That's what we really need. Or haven't we got enough guidelines already? And yes, we do. But basically, our CPOC anemia guideline includes all of these, the NICE guidance, particularly the British Society of Gastroenterology guidance, and basically every other guidance we could get our hands on is included. And this is just a quote I quite liked from Nata. Anemia should be viewed as a serious and treatable medical condition rather than simply an abnormal laboratory value. Because we don't think of it as one of those modifiable risk factors necessarily, but a lot can be changed. And this is just to remind me to say that blood transfusion does save lives and is often indicated in certain circumstances. So this is what our guideline includes as recommendations, background, definitions, types of anemia. And basically it's got the recommendations up at the front, including for patients. And then it's got the educational bit and algorithms and things in the second half. It's only just had board approval today. It's got some standards of care that organisations can be measured against around working to create pathways together. The really big thing is getting a full blood count early, making a diagnosis of what type of anemia and what's the cause of the anemia early. And then really working with the patient about how to treat and what to do with the operation. So there's a lot of information for patients in there and for people managing patients. We went through a huge amount of evidence. We had a big evidence review. Basically, a third of people are anemic before major surgery. Major surgery is counting as risk of 500 mils of blood loss or 10% of blood volume. It increases the risk of complications by about 3 times, in fact, if someone's anemic. But as an independent risk factor, it's only responsible for about 20% of the increase in complications. And there is a risk of blood transfusion, particularly immunological effects. So a lot of emphasis on the patient and what they can do on how to get iron and B12 in. A lot of discussion on not taking it with phytates, which reduces absorption, or with tea, and going to an alternate day dosing regimen, which is different from what's in the BNF. Much more on patients about iron, which can be got from a vegan or vegetarian diet, and on B12, which is very difficult indeed, if not impossible, to get from a vegan diet. And it's also encouraging patients to prepare for their operation in general. There are about 7 things that improve you've heard about them this morning, improve your ability to get through an operation without complications, improving physical activity, stopping smoking, that sort of thing, so you have a better physiological reserve. 3 of my kids are vegan, which I don't quite understand, but there we go. So I took a picture of that last week. Other forms of supplement are available. And this is from Canada. It takes the iron of 177 steaks to build a baby. It's like, wow, we have huge proportions of the population just never quite get up to what they ought to be in terms of iron level. And for organizations, the big thing is get the hemoglobin early, appoint a clinical lead, collect data, have a policy of what happens when results come in. I'm an orthopedic surgeon. In the last 3 weeks or something, I've had 3 different emails going, so-and-so's HbA1c is this, or their blood pressure's that, or their hemoglobin's that. Do you want to operate or not? I'm a surgeon. Of course I'm going to say yes. But if it had been got 6 weeks earlier or gone to someone that actually, I do care deeply, but there might have been a different discussion. So it's not just about anemia, it's about patient blood management. And there are 3 pillars of patient blood management. This is from World Health Organization. You've got to detect and manage anemia. So we're going to talk about that now. You've got to minimize blood loss. And that's the thing surgeons don't realize is important, but we need to. And it's the whole team. And then you need to make the patient as optimized as they can be. So if they lose some, they're okay. The definition of anemia. Now, this is one of the very contentious parts. It's quite clear it's slightly different for children. And then the big question is, should men and non-pregnant women have the same limit of 130 grams per litre of hemoglobin? Or, as the World Health Organization defined, 120 for women of childbearing years? And that's contentious, and it's probably out of date, and probably, as I said, lots of women have low iron, for example. We reference papers on the misogyny of iron deficiency and all that kind of thing in the work. But you've got to counterbalance that about declaring a large proportion of the population to be anemic when actually that's creating them into be patients. When they're not, they might get through their operation with no problem at all. So it's just that balance. So do read the guideline with that balance in mind. So iron deficiency anemia, are you losing too much or are you not getting enough? And you can think, well, you might lose it. There's quite a lot of reasons you're not getting enough. We talked a bit about poor diet intake, but also people who've had bariatric surgery can't absorb iron so well, and people with celiac disease can't absorb iron so well, and celiac disease is much more common than people realize. So are you losing more than you're getting in if you've got heavy periods or inflammatory bowel disease or something? You actually don't need that much because most of the iron is recycling old red blood cells. You only need 1 or 2 milligrams per day absorbed from the gut if you've got sufficient stores already. But if you're starting from a very low base, obviously you need more to build up. And you don't just need it for making red blood cells. It's used for oxygen transport, cellular respiration, ATP, and it's part of the immune system. So you need it basically for huge numbers of processes within the body. It's not just oxygen. Ferritin is a way of measuring. You measure serum ferritin, and if it's low, that's diagnostic of iron deficiency anemia. But if it's normal, because it's an acute phase protein, you might still have low iron. So you need something else. And the something else is TSAT, so transferrin saturation, to see, again, if it's below 20%, that suggests absolute iron deficiency. So this is a slide I borrowed from Abdul Raham et al. From the College of Physicians paper. I thought that was quite pretty, so I've put it there. And I just highlight the inflammatory disease, because inflammation has a huge impact on anemia. And some people have a combination of iron deficiency anemia and anemia associated with inflammation or chronic disease. And the problem with that is you've got increased hepcidin level, and that reduces how much iron is absorbed. And I realize you know all this, many of you do, but we're keeping it simple because I'm an orthopedic surgeon and we have to build up from there. So we've got functional iron deficiency, also known as anemia of chronic disease, or I believe in the States it's more commonly known as anemia of inflammation. It's the same thing. It means how you deal with iron is messed up. We've talked about ferritin, the acute phase protein. We've talked about hepcidin reducing the absorption of iron, and chronic kidney disease is the classic picture. So again, this is in the anemia of chronic disease or functional iron deficiency. You've got hepcidin causing problems, both with the macrophages that are recycling the red blood cells and how you absorb it from the gut. And then we've got B12 deficiency, and it's incredibly common. It's difficult to measure, 20% of the over 65s, and it causes many symptoms that actually might be mistaken for surgical presentation, such as joint pain. And it's, as I said, not present really in a vegan diet. And then we've got folate deficiency, which you can get from green leafy vegetables, broccoli, and so forth. But again, that produces a macrocytic anemia as well. And rare causes, you get hematological advice. So that's the kind of cause bit. So in the pre-assessment, there are algorithms about which pathway you go through. And the big thing is to consider a gastrointestinal cancer if it's a new anemia. And a third of men or postmenopausal women, it will be a gastrointestinal cause, not necessarily cancer, that's causing a new iron deficiency anemia. So you treat and you investigate at the same time. This is just to remind people, the NICE guidance for who gets a blood test have not changed. If it's minor surgery or intermediate surgery in someone who's ASA 1 or 2, they don't need a full blood count, or they don't get a full blood count. We're still only doing full blood counts in the people who need them. And then we've kind of standardized what tests are required. So everyone with a new low HB gets those: full blood count, iron studies, B12 folate, ferritin, reticulocytes, renal test to check you haven't got the chronic disease, and CRP. And then, if indicated, thyroid function test, celiac disease, group and save if you might need a transfusion, urine dipstick, and liver function test. So we've standardized that, so that will be easy for the nurses to manage. Oral iron does start working within 4 weeks, but can take a long time to bring stores up, particularly if someone's very deficient. And I'm sorry this is a bit fuzzy because this is directly from the guideline, but basically you're looking to see, is it iron deficiency anemia? Is it anemia with chronic disease, as in functional iron deficiency, or B12 folate deficiency, or something else? So there will be an algorithm. The nurses will be able to use the algorithm easily and help with suggesting treatment. Just to highlight that there's a UK Clinical Pharmacy Association that produces absolutely brilliant things around perioperative care. They've got a perioperative handbook, so do feel free to take a picture of that or look it up, play with your phones now, I won't mind. So anticoagulants, you don't want people to stay on anticoagulants and then bleed more, is what I've put that in there. Lots of words on here, but this is just to summarise iron deficiency anemia, functional iron deficiency, or B12 and folate and heritability. So that's it. It should be simple enough for an orthopedic surgeon or someone to be able to direct people in the right direction. If somebody's really, really iron deficient, you're more likely to want to treat harder perhaps with IV iron. And if they're less iron deficient, you try oral iron. It depends how long you've got and how low they are. So the British Society of Gastroenterology, a third of men or postmenopausal women with iron deficiency anemia will have a gastrointestinal pathology. Bear in mind, in the elderly, the risks and benefits from invasive investigations, because some people, bearing in mind the complication rate of an operation is 15%? Should they be having the operation at all? Should they be having something different? Do you want to do a colonoscopy in somebody who's only coming for one thing that's going to be simple? So it's balancing. So for that, you need the medic to make a shared decision-making discussion. And don't forget the renal tract. We've mentioned this already with the risks of anemia. They've got slower rehabilitation, longer length of stay, more likely to return to the theatre. I think this morning it said a higher risk of anastomotic leakage. I've mentioned shared decision-making. There's a new NICE guidance saying we should all be doing shared decision-making now, in the UK anyway. And what we need is the patients to be empowered to come to us asking what's the benefits, what are the risks, what are the alternatives, what if we do nothing, both about the treatment and about some of the stuff we do to people on their way to that treatment. I think the GIRFT report for anaesthesia and perioperative medicine said 50% of the patients having operations in the UK that require an anaesthetist are 65 years of age or older. And that's a part of the population where 50% of the population are multi-morbid. So we're dealing with incredible, and you do this every day, but we're dealing with a very balanced risks and benefits for people. And we need to be more honest with that, perhaps. So do look at our pages on shared decision-making at the Centre for Perioperative Care website, or Choosing Wisely UK. There are a number of things around the world on this. And when you get the results, they need to be individualized with a senior review, a senior clinician, a doctor or a senior nurse or practitioner, to talk about, should you delay the operation? What's the aim? Where are you going? Should you refer to somebody else, gastroenterology, renal, all that stuff? How fast should you treat? What should you do? So it's not, that bit needs thinking. That can't be down a pathway algorithm directly. And there's a finite number of interventions that are possible. We've talked about most of them. Erythropoietin is sometimes used with people, say, with kidney disease. IV iron, there are 2 preparations that work best in the perioperative phase, usually preoperatively. And again, the Royal College of Nursing has a really good leaflet on that. And we're referencing with hyperlinks all of these lovely leaflets that everyone else has. The PREVENT trial, you probably all know about, IV iron versus placebo. It probably wasn't powered well enough to show a difference in blood transfusion rate, or it wasn't clear on the criteria by which blood should be transfused. But it did show a higher postoperative hemoglobin and fewer readmissions. But it wasn't the answer to everything that a lot of people were expecting. Lots of things you can do intraoperatively. Just remind your surgeon to buzz things a bit more, maybe. Use tourniquets. Tranexamic acid is cheap and safe at all ages. And other things, the whole team can remind people about swab washing if you're getting or measuring outputs and inputs. There's some on transfusion triggers, so probably a hemoglobin, probably 70, unless someone has acute coronary syndrome where 80 grams per litre, but you have to individualise it to the patient and the symptoms they're getting. There's a whole section on pregnancy, because in the UK anyway, 31% of people having a baby have a major operation, of which 56% is an emergency, and that's what you're all doing all the time. So we need to get pregnant people as good as they can possibly be. And it's mostly iron deficiency, 25% of anemia in pregnancy. And the baby needs it for neurological development. Again, the World Health Organization has written much better stuff than us on anemia in pregnancy. And actually, for every 10 grams per litre increase in hemoglobin, you get 29% less maternal mortality or perinatal mortality. And then it's associated with all sorts of other things, such as birth weight and preterm birth. So again, this is from the British Society for Haematology. They did some guidance about what to do in pregnancy with iron and so forth. And it's really the same thing as you probably need to take the iron tablet every other day, because otherwise you get the hepcidin response blocking your absorption the next day. So that is probably best. IV iron's not licensed in the first trimester. And there's a particular issue with people who might be getting pregnant in the future about not wanting to give multiple or not wanting to give transfusions, exposure to multiple donors because of the risk of miscarriage later. In children, again, most children's operations are small, but there are lots of big operations, and before those, maybe a quarter, a third of children are anemic. Do consider tranexamic acid, and remember low iron affects neural development. And then there's a whole table in about how to give more iron to children before an operation. And it does work. A lot of them are very iron deficient. So here we go. For children, you're measuring some stuff like ferritin low, medium or high. Is it iron deficiency anemia or possible or unlikely? And you're looking for, basically you start treatment, and in the middle group, you still start treatment as if it's iron deficient and look for other things. So there's in the guideline an expectation about what should happen. And this has got lots of tips because different organisations have different setups. So somebody might be able to go to their managers and say, can we just have a point of care testing in the outpatient clinic? And they go, yes, here we go, have it. Or they won't. They'll go, you've got to train your staff, and then you've got to get the whatever about the point of testing sticks. But you can find, often people can find one thing that they can actually do in their centre. And once you've started something, you get the ball rolling, and then people are more likely to do your quality improvement projects. So this is kind of a menu of things people could try that's in our guideline. So do look at the CPOC website, cpoc.org.uk. We've got our other guidance on there already. Just bear in mind, perioperative care, you know this, it's incredibly important. 10 to 15% of operations have a complication. If you want to get your surgeons interested, you say, how can we reduce your complications? They go white. And they will go along to their audit meetings, their clinical governance meetings, and say, how can we change this? Even if it's an earlier start in theatre, even if it's not finding out the haemoglobin the week before, you can do it. Just say, can you work with one of the registrars to do an audit on something? And that's how we get working. You've heard about the reduction in complications with exercise and so forth. 14% of patients express regret after surgery. 10% of operations are cancelled at short notice. And there's a huge variation in who's admitted rather than being a day case. But this is it. People who know the stuff and want to do it, there's a huge difficulty of getting it mainstream. So my suggestion is the little bits to try and get people interested, show them something that works. We've got the evidence. It's on our website about how perioperative care works so much better than pretty much anything else. So we need to get people to do it more, particularly that reducing complications, reducing bed stay, getting more people day caseable, because that after a pandemic means you can get your green areas going better. We've got loads of guidance: diabetes, preoperative assessment and optimisation, frailty, enhanced care, day surgery. Do look on our website. These are collaborations with other people. As you can see, I love logos. They're all up there. Lots of people. It's not just us. And we've got lots of resources that you just pick out a page, get your pre-assessment clinic to do it like that. Shared decision making. This is for complex patients when there is a choice. Some people there isn't a choice. Benefits, risks, alternatives, doing nothing. And get the nurses involved in the risk stratification. Some people are straightforward, but they still need that nudging, I think it was called earlier, to optimise, to be as good as they can be. The complex patients, you need a doctor or senior clinician balancing everything. Several things we talked about: the optimised patients to reduce that complication risk. And the exercise isn't just heart, lung and fitness. It's got a metabolic effect, empowering and pain management. And nutrition we've talked about in regards to anemia. Just a slide from movingmedicine.ac.uk. Please use that. It's Centre for Perioperative Care helped with their pages on perioperative care about how to get people fitter before an operation. So we all know perioperative care is better for the patient, better for the staff, better for costs. We've got something coming out soon. In fact, I think the consultation period ends tomorrow on the National Safety Standards for Invasive Procedures. So do look at this. It's about the WHO checklist. It's about reducing never events. It's about standardising what you should, when an implant goes in, so the wrong implant doesn't go in. But we need your help. So when that comes out in September, again, same as the anemia guidance, do help. Listen, it's like the prep stock block. So we don't get bad stuff happening because everyone's so busy. So what can you do now? Right now, you can sign up for the CPOC newsletter, cpoc.org.uk. You can do it now, I won't mind. Sign up for the newsletter, tell your friends, tell your hospitals, put it into your own newsletters, updates. But we're giving out bite-sized information, links for everybody across patients and everyone. Mention Centre for Perioperative Care. Create a meeting. Go to your clinical governance. Say we're going to have a meeting today about this new guidance on frailty or diabetes or anemia, and get people to come and listen and talk about it. Force them to read it. So this is my summary. Detect it early, rearrange your pathway so you can detect it early and do something about it that's the right something. It's finding the type, diagnosing the cause, and treating and involving the patient. And as I said, we've talked about possibilities. There's only a finite number of things you can do. But it's not just the anemia, it's patient blood management, detecting and treat, minimise blood loss, optimise physiology. And on the right, CPOC_news if you follow people on Twitter. If you follow me on Twitter, at Scarlett McNally, you'll get lots about why we haven't got cycle lanes in Eastbourne and need lots more. So that's the caution if you follow that. But we'd be happy to have feedback from you about the anemia. But please try and use it. We're doing our best, but we need you. Thank you.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.